Hi, my name is Dr. John Mcgarry with Plano Orthopedics and Sports Medicine. I work in the sports medicine department. Mainly shoulders and knees are my specialty. I do a lot of rotator cuff injuries, a lot of knee injuries such as meniscus tears, ACL injuries. In the shoulder, I focus mostly on rotator cuff, instability, and things of that nature. I also do some joint replacements, but mainly focus on sports medicine. The first case I have today that I want to show you guys is a shoulder case. A 75-year-old female who presented to me, and her main complaint was weakness and pain in the shoulder for quite a few months. She had already tried anti-inflammatories, rest, and her own home exercise program, which she failed. When she came in to see me, she could move the arm, but it was a very painful range of motion. She had significant weakness, and I got a set of x-rays first and then examined her. Behind me are her x-rays, where you can see over here on this x-ray of the shoulder, the anterior to posterior view of the shoulder, she's got a little area of calcium deposited in the shoulder, which clues me in that this could be a source of her pain. I started treating her for the calcific tendonitis, which is what this represents on the x-ray. So we started with a steroid injection and some physical therapy. She had a return visit to see me about 5 to 6 weeks later. She was slightly improved, but still having some issues. So we went with an MRI. On the MRI, it confirmed that she did have a calcium deposit, but also a rotator cuff tear. So at that point, I counseled her, and we came up with a plan to do the surgery to repair the rotator cuff and remove the calcium deposit, evaluate some of the other structures inside the shoulder, and remove any bone spurs at that time. So we proceeded with the surgery, went very well, and she's recovering nicely. So the rotator cuff is a group of 4 tendons and muscles that help stabilize the shoulder, and it's very common to have a tear, especially as we get older. It's a certain area of the body that can wear out over time, and it's not uncommon to have a tear. When those tears become symptomatic or full thickness tears where they're torn all the way through, mainly patients present with pain, weakness, a lot of pain at night where they can't sleep very well. And that's probably the number one reason many people come in, is because of the pain at nighttime. And so a lot of times we repair those, and I have some instruments in front of me today just to kind of show you how we would go about repairing a rotator cuff. So here's a sawbone model of the proximal humerus, which is the upper arm with the ball of the shoulder joint. This tissue here, this represents somewhat the superior rotator cuff, and this should be attached to the bone right here, but it's representing a tear. So I have some instruments here that I can show you some of the techniques we use to, number one, put an anchor in the bone, use the instruments to pass suture through the tear, and pull the tear back down to the bone. So in front of me, I have just a model that represents rotator cuff and the shoulder bone. So this tissue here represents this tissue that's torn, and the edge of the bone is represented by this sawbones model. So here we have 2 anchors that I tend to use quite often. This is a 4.5 anchor made of a biocomposite material. This biocomposite material is resorbable. It will be gone in a few months, maybe up to a year before it reabsorbs, so it gives plenty of strength before it reabsorbs, and therefore you are not left with metal in your bone. Some of the instruments that we use, this is one of the instruments we use to pass the suture through the tissue, which I'll show you in a minute. We also have instruments that are, since we cannot put our fingers in the joint, we have instruments that we can grab the suture with. So I'll demonstrate how we put an anchor in the bone and how we pass suture. Remember, this is all done if the skin is out here. We have little holes in the skin with cannulas, so I'm coming in through a cannula to put these instruments into the shoulder joint. So this is the first instrument that we use when I've decided which size anchor I want. This is called a punch. So I put the tip of it at the bone, and then I'll take a little mallet and make a hole in the bone for the anchor. So after we make our pilot hole, you can either, if it's really hard bone, and sometimes younger people, sometimes you'll use a tap, just to get some threads started. So I'm going to pick a 5-5 anchor since this was a 5-5 punch, and I'm going to thread the anchor into the bone. We have a little line that says when to stop, and then you deploy the sutures. Most anchors that I use have 3 different sutures associated with them, so a total of 6 sutures, 2 limbs per suture, and then we systematically pick colored suture. They're all 3 different colors so you don't get mixed up. Load the suture and pass it through the tendon. So we would put a grasper into the joint to hold that as we remove the passer, and now we have 1 suture passed. So once we have the sutures passed, we tie. I'll just show you how we tie. Usually these are done through cannulas, so these are all sliding knots. All right, so I don't have normally I would clamp that. Once you have your knots tied, we can then cut the sutures. And so as you can see, that's nicely secured the rotator cuff back to the bone. All right, so we went ahead and did the surgery. I fixed her rotator cuff. I removed any of the bone spurs that were causing some impingement, and we got rid of the calcium. She's about 3 to 4 months out from surgery now, doing very well. She has near full range of motion. Her strength is getting much better, and she has almost no pain and is sleeping much better at night. As you can see on the x-ray over here, this is her after x-ray, where that calcium deposit you saw on the first x-rays has now been removed. So when you have a rotator cuff repair done arthroscopically, full thickness tear usually takes about 8 weeks for the rotator cuff to heal back to the bone, but that's just the beginning. Then you have to start working on range of motion and strengthening. So a full recovery back to full activities, lifting overhead, is oftentimes 4 to 5 months. So the surgery for a rotator cuff is an outpatient surgery. The actual surgery itself takes about an hour to perform, sometimes up to an hour and a half if it's a larger tear, and they go home the same day. The pain medication is necessary for at least a few days to maybe a week afterwards, and we do send people home with a narcotic for 1 week. But they also do get a block in the surgery, so the anesthesiologist will do a block in the nerves exiting the neck that innervate the shoulder, and that block really helps for a couple of days to minimize the pain. And if you can get the pain taken care of for the first 2 days after surgery, patients are much more comfortable. That concludes this case. If you have any questions in the future, you can always leave questions in the comment section. If you have anything you would like me to discuss, then you can also put that in the comment section. So again, thank you for joining us today. Once again, I'm Dr. John Mcgarry with Plano Orthopedics and Sports Medicine.